Hi guys, how are you? It's Pam Turner, Dr. Pam from Academic Coaching for World Changers, and I'm trying to make a couple of shorts as quickly as I can. If you know me at all, you know that I work all of the time. My business keeps growing. That's all thanks to you guys. I definitely appreciate it. But I just want to come over some of the medications. I hear that a lot. So no matter what test you're taking, and we tutor all tests. We tutor to all of the tests, right? We just want to make sure that you know your medication list. So this is exhaustive. I'm going to tell you that no test has this many medications, but you need to know some of the basics. Okay. So I'm going to start off with my antipsychotics. And of course, my antipsychotics are going to treat schizophrenia. Schizophrenia is known for its schizophrenia has both hallucinations and delusions. And one of the things you always need to know, of course, is going to be the time frame. So, in the real world, of course, many times you walk in and you see a client who's diagnosed with schizophrenia, and that's not always the case. So, if you look here, you'll see that here are the diagnosis requirements. So, brief psychotic, less than 1 month, schizophrenia a form of schizophrenia that's going to be between 1 month and 6 months, and full blown schizophrenia happens at 6 months. Okay, so that's what I'm looking for when I'm looking at my brief psychotic disorder, schizophreniform schizophrenia. I also hear about schizoaffective disorder, which includes both the schizophrenic activities, hallucinations, the delusions, right, disorganized speech, as well as bipolar one, which is my affective disorder. That's mood. So to treat both of them together, schizoaffective, I'm going to have both a antipsychotic and as well as a treatment for the mood disorder. So most often it's going to be lithium, right? And then we'll go over the list of antipsychotics. So that's the difference between the three of those. Okay. Well, let's see here. So going back to my medication list. So we're looking at antipsychotics, the medications that are prescribed the treatment of psychotic issues. So that's both schizophrenic, which includes hallucinations, delusions, and disorganized speech. So, psychosis is a medical term. If people have psychosis, again, that's both of those things. So, you'll see they're divided into typical and as well as atypical. My atypical are my newer ones, and those are most often the ones you'll see on the test, but you might see one of these. Also, on most of the tests, I do see it this way. Unless you're taking maybe my psychologist exam, most of the other tests, you just have to know they're looking this way. They're not making sure that you're a pharmacist. They're going to give you both of those so you can have an idea of what it looks like. So you see Thorazine, let's see what else. Prolixin, you might see, Navane, Malaril, and Haldo. Those are atypical. I'm sorry, those are typical, which means they've been around for a very long time. Okay, tried and true, right? So you might even say the Thorazine shuffle. That's I used to see that sometimes because that was Thorazine. Okay, so my atypical, those are my newer ones. So my typical ones, most atypical antipsychotics were discovered recently. Clozapine is also referred to an atypical antipsychotic, even though it was around more than 60 years ago. But they're usually known as my second generation. To be honest, experts really aren't sure how they work, but what we know is they block certain neurotransmitters in the brain. One of the things that we think is with schizophrenia is too much information is getting through the synapses, right? The neurotransmitters. Too much is getting through too quickly. So my current, the most common atypical antipsychotics, Abilify, Clozaril, Geodon, Risperdal, Seroquel, and Zyprexa. Those are most often the ones you're going to see. Also, remember that my atypical ones, are less likely to cause tardive dyskinesia. It doesn't mean that it doesn't, but it's less likely. If you're not sure, tardive dyskinesia is actually just a side effect of the antipsychotics. It affects your central nervous system. It's not a muscular disorder, it is a central nervous system disorder. So it's very prominent in your face. See the ticks in your face. However, it actually does appear in all of the body parts, your legs, your arms, all of those things are when you're going to see tardive dyskinesia. That's one of the reasons people don't want to take it, right? So, you have schizophrenia, you're responding to external stimuli, you're hearing and seeing things that other people don't hear and see. So, of course, adding that on top of that, we don't want to do that. The medication that works to stop tardive dyskinesia would be Cogentin. Cogentin is a medication that is typically made to stop the results, stop the side effects of the antipsychotic. Okay. Remember, when it comes to these, we really believe that they go away once you stop taking the medication. It does go away. One of the things when you see that term deinstitutionalization, that has to do with the fact that we had these new medications or antipsychotics that were available in a shot or a pill, or I'm sorry, a shot or a patch that would guarantee that it would last longer. Before, when my schizophrenics lived in institutions, they needed the shot every day. So that term deinstitutionalization, because of the event of shots, that allowed for us then to have less, to do some closing of the institutions. Cogentin is the term that I used, right? That is the medication that fights the side effects of any of these antipsychotics. Okay. Again, so they don't go, they're not permanent. They're caused by the effect of the medications, and it's not a muscular disorder. It's a central nervous system disorder. And next, I'm going to talk about some of my antidepressants. So my current antidepressants are my SSRIs. Okay, so SSRIs are what we're using now. What we believe is the problem with depression and anxiety inside of my body, it doesn't look any different. What we believe is the neurotransmitters, as the brain fires, right? It sends more information over. That what's happening is, for some reason, the other transmitter is not accepting what's being sent. Let me just kind of show you what that looks like. This is not going to be, it's not a test question, but I just kind of like to show you how it works. I think that's kind of cool. So we look at neurotransmitters. Picture's getting in the way. I'm not able to pull that up. Okay, so this is not working for me today. Okay, I'm going to come back and show that, guys. I'll show you what it looks like with the neurotransmitters. Let's go back. Okay, so then the SSRIs on the inside of my body, like I said, it doesn't see it any different. So the ones you're going to use, the serotonin, is the most common SSRIs: Celexa, Lexapro, Luvox, Paxil, Prozac, and Zoloft. Again, those are my newer ones, okay? Um, Zoloft is the one you're going to see most often that works best with anxiety. I said before, my body doesn't see a difference. It doesn't recognize any difference between anxiety or depression. Either way, my neurotransmitters are not accepting the information. My MAOIs, that's the second class. And if you see, these are actually the first class of drugs we came out with. And MAOIs are the last option. Okay. With MAOIs, and you'll probably only recognize maybe Parnate or Nardil. They've been around for a very long time, so we really don't use a lot of those anymore. My tricyclides, those are the ones we had before the SSRIs. Anafrafil, Elavil, maybe, Pamelor, I like that name, Pamelor, tofranil, a few of those you might see. Okay, so those are my tricyclides. Those are the ones that came out just before the SSRIs. My MAOIs were first. Okay. And you'll see these. So these are SNRIs. They're selective norepinephrine reuptake inhibitors, which is just a little different than my SSRIs. So they're really looking at the amount of norepinephrine in the brain. So Effexor, Cymbalta, those are definitely the newer drugs you'll see. Okay, and again, you might see those on the test as well, but it's not a trick test. They're not going to give you, they're not going to try to make you guess. It's a reading test. You just really have to read and figure out what the question might be. My anti-anxieties, right? I watch always, if you've had any sessions with me, I always say in the movies, I say, give him 2 cc's of Ativan, right? And he passes out just like that. So the Ativan anti-anxiety, they work very quickly. They are great for a moment, right? So acute anxiety, panic attacks, amazing. So if the question says, what is the most common, I'm sorry, what is the best choice to use? I'm going to use definitely an anti-anxiety because that's the best. If it asks me which one I can use long term, that's going to not be one of these. So Ativan, Buspar, Klonopin, let's see, Trexine you might see. I'm trying to name the ones that you definitely are much more common. Okay, so those are ones that you might see. Valium, of course, and Xanax. And again, those work immediately. Within 15 to 20 minutes, you're feeling that anxiety has gone down and you're feeling great. I don't like the dentist. So sometimes my dentist will give me like a small dosage of Valium or Xanax before I get to the dental office because it makes me very anxious. However, it's addictive, right? That's why we can't give these every day. We're just using these on a uh, maybe a PRN basis. That's what it looks like. If it asks which of these, again, is the best to work with GAD or any of my other anxiety disorders, most often the answer is going to be Zoloft. All of the antidepressants take 2 weeks to get into your system, right? So that's when we know if we're working, if after 2 weeks. So let's see here. My stimulants, of course, Adderall, Dexedrine, and Ritalin. A lot of my clients now are like, Dexedrine, what is that? So if you've been around for half a minute, Dexedrine used to be a really popular diet pill. It was on the commercials in like the 60s, 70s, probably mid 70s. They were sold over the counter and it was known to suppress your appetite. So all of the other stimulants also suppress your appetite, but Dexedrine is a stimulant and it was originally used to suppress the appetite of women, and most often it was women that it was sold to. Adderall and Ritalin are the ones you're going to see on the test. I don't think you'll see this, but there are some longer lasting. So, like the Concerta and the Adderall have like an XR, which is a longer acting pill as opposed to ever taking it every 4 hours, because most of my stimulants you're going to take every 4 hours. Okay. My mood stabilizers, those are things that I would use if I mentioned before, a schizoaffective disorder, but it's also something that I'm going to see if I'm using, if I have bipolar 1. Let me pull that up for you and just kind of see what that looks like. I've got it for you somewhere. There we go. Okay. So my bipolar 1. Bipolar 1 and bipolar 2, this is where I'm going to see most often lithium. Lithium is kind of like swallowing, those little right? Those the batteries, right? That's we don't really want to swallow lithium batteries anymore, right? The tiny ones. So what we do know is that lithium does cause toxicity. It causes a buildup of the lithium in your system. It affects both your kidneys as well as your liver. Old school, been around for a very, very long time. In the real world, we're not using a lot of lithium anymore. But if lithium is the choice, what you're looking at is lithium requires blood work because you're making sure that you don't get the toxic buildup and really die from that. So if you don't see lithium, what you're looking for now is going to be one of my anti-seizures. That's going to be a Tegretol or a Depakote. Those are the most common ones. So again, if you don't see lithium, because lithium most often for the test is still the right answer. If it's not there though, Tegretol or Depakote, anti-seizures. Remember, bipolar 1 and 2 are both going to start off with major depression. Major depression as diagnosed of 2 weeks. 2 weeks can't get out of bed, don't want to shower, eat, overeat, sleep, don't sleep. All of those suicidal thoughts. I think I'm the worst person ever. 2 weeks. 2 weeks is the minimum that it takes to diagnose major depression. Okay. So if you see then if my mood lifts and it goes all the way up, that's going to be a full manic episode. So bipolar 1 is a full manic episode, 5 to 7 days of a full blown manic. Sleeping with everybody, shopping, doing things you would never do. Hypomania, you'll see the depression only goes up to 4 days, right? So hypo means less. Hypomania, you're really not going to see that. You might not even notice if the person has hypomania. Cyclothymia doesn't quite meet the requirements for bipolar 1 or 2. So it is a lower level. If you see the cyclothymia, they're my dark green, right? You see it does it. It's not quite major depression. It's not quite hypomania. So cyclothymia, 2 years in adults, 1 year in children. I'm still using the same medication. Okay. So bipolar 1, bipolar 2. And if I have a schizoaffective disorder, then I'm using one of my mood stabilizers, lithium, Tegretol, or Depakote. Okay. Let's go back to major depression. I want to just touch on that for a little bit. So what I said before is major depression really is 2 weeks. 2 weeks, can't get out of bed, don't want to do anything. So if we look at the symptoms of major depression, chronic emptiness, unyielding sadness, hopelessness, restlessness, fatigue, right? All of those things will be defined as major depression. Major depression may not be triggered by anything in particular. And for the test, most often, if it's triggered by something, it's going to be like grief, like a bereavement disorder, or maybe even an adjustment disorder. Something happened, some kind of crisis happened, and you're adjusting. So when it comes to depression, again, what I'm looking for is 2 weeks, 2 weeks of not being able to get out of bed. Put it down right here. There we go. For major depression to be diagnosed, the person must be experiencing 5 or more of the following for the same 2 week period. Okay. Depressed mood, diminished pleasure, significant weight loss, weight gain. That is where my major depression is diagnosed. Up here, it did talk about seasonal affective disorder, SAD. If you spent any time with me, you know I have SAD. I really do. I don't do well when the sun is not shining. I have a light box that mimics the sunlight. So SAD is considered part of major depression. However, SAD is only during this period. It doesn't have to be the winter. It can be birthdays, holidays, any season that definitely has that effect on you. Okay. Peripartum, right? The type of depression that is commonly known as postpartum. One of the things that we're looking for with a postpartum depression is we're going to ask the how long it's been going on. And persistent depressive disorder, PDD, you might see as well. PDD is the 2 years in adults and 1 year in children. So it's again, it's more than 2 weeks, but the test questions really may try to trick you. It may say a 21-year-old has been sad for a week. That doesn't qualify for PDD, so that would still just be major depression disorder. Okay. So some of the most useful, most prescribed psychotropics, these are the ones that you'll definitely see. And I just kind of thought this was interesting to look at the numbers. Xanax, of course, that is my benzodiazepine. Zoloft is an SSRI. Celexa, antidepressant. Prozac, antidepressant. Ativan, benzodiazepine. Trazodone, that's an old school antidepressant. It's actually a tricyclide, old school. Lexapro, Zymbalta, Wellbutrin, and Effexor. The Wellbutrin and the Effexor, the XL and the XR, those are the newer ones. And the XL and the XR are supposed to have a little bit, they are less likely to cause the sexual disorders that sometimes being on a antidepressant causes. When you see those questions, I'll remember you are not a doctor. So whether no matter if you're an LPC, an LMFT, anything, you're not a doctor. So if someone comes in and they tell you they're on an antidepressant and they're having difficulties with performance, sexual performance, we send them to the doctor. We stay in our lane, right? We don't prescribe medication. We don't tell clients about medication. We stay in our lane. I'm just going to run over a couple of quick questions, guys, so you just get an idea of what it may look like on the test. The medication Prozac. Prozac is used to increase what? My serotonin. Yes, it's an SSRI. Serotonin, selective serotonin reuptake interrupters. This question, a 43-year-old male is experiencing the following symptoms: auditory and visual hallucinations. And I'm going to remind you that all 5 of your senses can hallucinate. You can taste things, you can smell things, right? So what we're looking for is making sure those hallucinations occur in multiple places. That's what makes it a hallucination. So I smell my skin rotting. I can smell it. I smell it at home. I smell it at school. I smell it at work, everywhere. Another common one, of course, is gustatory. They're poisoning my food. I can taste it. I can taste it, right? So what I'm going to use, I know that Xanax definitely is not my answer because Xanax is a benzodiazepine. I know that Paxil is going to be an antidepressant, and I know Lamictal is many times used for bipolar. So of course my answer to this one is going to be Abilify. Excuse me, that is one of my antipsychotics. Okay, and then my last one, oh no, got two more, sorry. Which of the following medications is classified as a benzodiazepine? So, right, again, Geodon is going to be an antipsychotic. Risperdal is an antipsychotic. Abilify is an antipsychotic, right? So I know Xanax is going to be a benzodiazepine. Those are addictive, as I said, so we're only going to take them on the PRN basis. And this one, again, it kind of looks like a question of what it may look like, again, on the test. A clinician is reviewing a client's medical history as a part of the intake interview. The client reports that he's been taking Risperdal, hint, hint, antipsychotic for the last several years, after being replaced with Haldol, hint, hint, antipsychotic, right? The client is most likely being treated for which one? So I do know that those are my antipsychotics, so that's schizophrenia. Adjustment disorder, most often, so we're looking at an adjustment, so we would use an antidepressant if it continues. My ADD, of course, is going to require one of my stimulants, and my depression would, again, one of my antidepressants. Interesting note about my stimulants, those are known to have a paradoxical effect. So the paradoxical effect is the opposite, right? Sorry, paradoxical. It's the opposite. So we know that if we're looking at strategic family therapy, the paradox is the opposite. A paradoxical directive is the opposite. So when it comes to medications, ADHD medication being a stimulant has the paradoxical approach, which is the opposite. Because for most of us, if we're not ADD and we take a stimulant, it sends us way up, right? Off the chart. However, if we are ADHD, the effect is the opposite. It helps us calm down, process thoughts, and make better decisions. Okay, I just wanted to give you a short, guys, on some of the questions you might see regarding medications. Again, I don't suggest you spend years and years and years or lots of time learning in detail all of them. Get a really good grasp of the ones that are most common. One of the other things that you'll see if you're taking the social work exams, you're going to see some of the most popular ones on TV as well. Advere, Lantus, let's see here. What else? Trying to think of the others. The ones you'll see on TV, the ones that are the common ones, you'll see those as well, especially on my LCSW, my clinical exam. Hope you enjoyed this short, guys. Remember, you can always check us out for individual sessions. It's at drpam2020@gmail.com. You'll see it at the bottom of this. And also remember to subscribe to our channel. I try to release videos pretty often, and I'm trying to get those shorts out, and you'll be notified you'll be notified the moment we release one. So I appreciate you hanging out with me. I appreciate you using academic coaching for world changers. And most of all, we really, really, really just hope that you pass this test. The goal of my business, really our mission is our mission is that we don't think that this test should stop any of our clients from doing what we believe God has called you to do. There's a plan in your life, and this test has nothing to do with whether or not you're a good clinician. This test has to do with whether or not you're a good test taker. Thank you very much, guys. Keep on changing the world, and I'll see you hopefully in a live session one day. Bye.